All right, so we talk about intro of the hip here in this PowerPoint. Okay, so there's two main joints in the hip. Okay, there's the iliofemoral, which is that true ball and socket joint, which is very, very stable. Excuse me. Okay, unlike the shoulder, okay, the iliofemoral joint, okay, is a really nice big socket, okay, where that head of the femur kind of sits in. Okay, very, very stable, very, very hard to have any kind of dislocations. Okay. The next one is going to be the sacroiliac joint. Okay, and I'll show you these examples here in a minute. There is not a lot of motion that occurs at this joint. This occurs a little bit at the back end. So if you were to see my screen, the sacroiliac or SI joint is this little line right in here. Okay, where the sacrum and the ilium kind of combine. Okay, so where the iliofemoral joint, okay, is this one right here. Okay. The hip is a very, very large, very stable structure. Okay. There's about 27-ish muscles, okay, give or take, depending on how you want to define it, okay, that attach somewhere at the hip. Okay. Females have a wider hip, or so wider hips than males due to childbirth, because this canal right here has to be a little bit wider to allow for the head to fit through. Okay. Thus, for wider hips, females need more control. Okay, of everything lower body wise as a result. Okay, so more they require more mass to control all those hips. Okay, not many injuries happen at the hip. There are a few that happen. Okay, some are just kind of like pain in the butt, literally, but not a lot of crazy stuff that happens. All right, we'll go through some anatomy real quick. Okay, so here's some basic bones. Here's the ilium. Okay, here's the sacrum. Okay, here's the SI joint right here, sacroiliac. Okay, here's the femur. And here, let's see, I think I want to go over intently more on some of these. Okay, so right here, okay, here's the SI joint. Okay, not a lot of motion occurs here. It's the normal kind of rotation that occurs. Okay, almost like this rotation there. Is about 3 to 5 degrees, which is really not a lot. But if for whatever reason you have issues or a lot of laxity in the ligaments that hold that, because there's a ton of ligaments that kind of hold all this together, both anterior and posteriorly. If those ligaments are ever like stretched out or damaged or whatever it is, and there's more than like 3 degrees of rotation, there's 3 to 5 degrees of rotation, usually results in some pretty extreme pain or issues. I mean, like 3 to 5 degrees is like, if you can see my hands rotating right here, that's what it is. Okay. Let's see. So just some little palpation-wise stuff. Okay. This right here is the anterior superior iliac spine. Okay. And then here's the anterior inferior iliac spine. Okay. We often term this the ASIS and the AIIS right in here. Okay. So these are important sites for attachments to some muscles. For example, the rectus femoris, one of your hip flexor muscles, attaches right here, okay, to the AIS. Okay. Other things, the ischium, okay, this big structure right here. Okay. This is really the biggest thing that we sit on. Okay. So if you were to put your hand on your butt right now, okay, that's the kind of bony things that kind of stick out. Okay. Right here is your pubic symphysis. This is another kind of joint in the hip. I probably should have mentioned previously. Not a lot of issues happen here. There was a connection here to where there's a little synovial joint right there. And it just kind of keeps things kind of together. It can be damaged, especially some females can have issues with this after childbirth. Just because everything kind of loosens up, especially right there. There are a few cases I've seen to where some college and professional athletes have issues there, like pubic symphysitis, which is just really, really intense pain down in there. There's a lot of rehab to really do a lot of kind of hip control issues to try and maintain that. Okay, your acetabulum is here. Okay, the best picture. Let me go back. Okay, so your acetabulum is the hip socket. Okay. Kind of right in here. So this is what it is. It's hard to identify this, but this is an inferior use. You're looking up at the pelvis. Okay. So this is the really, really, really deep hip socket. Okay, and it's not really shown in this picture. See anything else? I want to talk about this. Here's the crest. Okay, the iliac crest. Okay, this is that thing that kind of sticks out on their sides a little bit higher. Okay, not a lot of tissue usually covers that. As a result, you get a lot of hip flexor injuries. I'll talk about that here at the very end. Oh, here's a good picture. Okay, so this is your acetabulum. Okay, this big socket right here. Okay, here's the head of the femur. Here's the neck, or the femoral neck, which is usually very, very dense, compact bone. Okay, here is the greater and lesser trochanters. Okay, so these are sites of a lot of the major muscle attachments for the hip that contributes to a lot of the big control factors. Okay. You do have a hip labrum, okay, in there. It is not as super important as the shoulder. Don't get me wrong, it's still important. But with the hip labrum, you can do without it. Okay. Sometimes they'll go and they'll take out sections of it because it's not as of a big shock absorber as some other areas, or doesn't help a lot with stability. It does help a lot, like keeping things kind of like lubricated for ease of motion to occur. Okay. There is a ligament here in the head that keeps the head of the femur kind of deep into the socket. Okay. And within that head of the femur, there's also an artery. Okay. There's a very, very important artery that keeps blood flow to pretty much keep nourishment to the head of the femur. And a lot of times with femur dislocations, as rare as they are, they do happen. But that ligament and the artery is severed. As a result, the head of the femur can turn necrotic and waste away, and will result in that individual getting a hip replacement. Okay. Let me think. Anything else I want to talk about in here? That was really this one. Okay. Muscle-wise, it should be a recap from the recent module on the knee. Okay. So let's see, I want to start this. Okay, deep in here. Okay, we have your psoas major. Okay, and your iliacus. Go down, they form your iliopsoas muscle. Okay, one of your deep hip flexor muscles. Okay. Over here we have your tensor fasciae latae. Okay, attaches to your IT band. Okay, the other muscle attached to your IT band is your gluteus maximus. Here we can see attached to that what nice big IT band. Okay. We have kind of your medial compartment. We have pretty much all our adductors. Okay. Pectineus, adductor magnus, adductor brevis, longus, and then our gracilis, which is kind of like our groin muscle deep in here. Here, they're called the anterior compartment. Okay, we have your quads. Okay, so your rectus femoris, your vastus intermedialis, vastus medialis, and vastus lateralis. Okay, back in the back. Okay, we have your gluteus maximus. Okay, your butt muscle, big nice one. On the side, we have your gluteus medius. Okay, which is a very, very important muscle for control, lateral control. Underneath that, you have your gluteus minimus. Okay, another really, really good control muscle. Here at the posterior side, okay, we have our gracilis here, our groin, as I mentioned before, up right in here. Okay, we have our hamstring muscles back in here. Okay, so biceps femoris, and then you have your semitendinosus and semimembranosus. Okay, all really, really important structures. So actually under semitendinosus and semimembranosus muscles, you can actually palpate the tendons down here on the sides. So if you kind of feel behind your knee, kind of up higher, just above the joint, you actually feel these like long ropes. Those are your hamstring tendons. Next, here's a good refresher on hip flexors. I talked about this a little bit in the knee PowerPoint, but the big hip flexor muscles are going to be the rectus femoris and then your iliopsoas muscles. Okay, so your rectus femoris attaches to your tibial tuberosity, okay, down in here, and then but it originates at the anterior inferior iliac spine, which is this little module cut up in here. Okay, so this is anterior superior. The inferior one's just about right in here, just underneath all these muscles. Okay, So for your rectus femoris, the action that it does, so it does do hip flexion and knee extension. Okay, because that is a two joint muscle. Okay, so iliopsoas, okay, so it has two regions, okay, because your iliacus, which is the iliac fossa, kind of deep in here, okay, and then the other one, okay, for psoas major is the vertebral body, okay, and the transverse process area T12 through L5. So that's a very, very big origin spot for this monster muscle, okay, and it inserts in the lesser trochanter, which if I went back a little bit, is right up in here. Okay, so the actions that it does hip flexion, okay, helps with the anterior pelvic tilt, okay, and it also does, I didn't mention this in here, but it also does hip external rotation along with that, just because of where it kind of attaches into. Okay, here's some of the deeper lateral muscles. Okay, so we have gluteus maximus and TFL, tensor fasciae latae, okay, attached in the IT band. Okay. Underneath that, okay, we have gluteus medius, okay, very, very, very important stabilizer, okay. Very important to train with distance runners, okay, because a lot of people always forget about the stability, the lateral stuff, so you see their form start to fail later on, especially if they don't like really train a lot of their lateral stabilizers. Okay. Up here's a really good picture of your psoas major and your psoas minor, which we don't want to talk about too much, okay. That's how high up and how deep that hip flexor attaches. Okay. Underneath that, we have your gluteus minimus. Okay. Back here, we have your piriformis muscle. Okay, we'll talk about your piriformis here in a minute. Okay. That kind of attaches over here on your sacrum, and then attaches to your greater trochanter up in there. And obviously you can see there's a ton of other little muscles in here that I'm not going to really focus a lot on right now. Okay. Here's a good picture of your IT band, how big and thick that thing is, okay, and the muscles that attach to. Okay, so if you have issues with like some kind of IT band syndrome, runner's knee, whatever it is, you really want to attack these two muscles, okay, to fix the problem. And don't really foam out, don't roll out your IT band, because that's not really doing anything, because you can't stretch out your IT band. You can only really elongate and stretch out these two muscles. Okay. Underneath, okay, this is your rectus femoris right here. Okay, and then underneath your IT band, you see your vastus lateralis. Okay, your biceps femoris is here just behind on both pictures. You can see that's a lateral muscle, the lateral ist hamstring muscle. Okay. Okay. Here's another good picture of the iliopsoas. Sorry, psoas major. Okay, attachment, kind of really deep. Here's a good picture of that piriformis muscle. Okay, here's another one up here. Okay, where it attaches. Okay, so right underneath your psoas, right underneath your piriformis muscle is your sciatic nerve. Okay, where it kind of runs down. It's a very, very massive nerve that comes off of your the inferior side of your vertebrae, and it kind of innervates a good portion of your lower leg musculature. Okay, a lot of people will complain of like sciatica and stuff like that, and so usually as a result of that really, really tight piriformis, because it runs right underneath. We'll talk about sciatica here in a little bit. Okay, and here's some of your other muscles. Okay, gluteus minimus, obturator externus and internus, and some other ones. Okay. Let me see, anything else crazy about this? Okay, lower cross syndrome. Okay, so this is a kind of distortion syndrome. Okay, that is pretty popular. Okay, characterized by some kind of like anterior pelvic tilt of the pelvis. Lower extremity muscle imbalances are usually the common issues. There could be other things that bring it on. I'll talk about here in a minute. Okay, it can result up to 80% of lower back pain for adults. Okay, so oftentimes if you like your back kind of hurts and you kind of bend over and it feels better, it's usually a result of this. Okay, so it's usually characterized by a tight back extensors. Okay, so your low back's really tight hip flexor. Okay, so everything along this line is tight, and then weak abdominals. Okay, and then weak glutes and hamstrings. Okay, there's that cross. And there's always more to it for low back pain than just this, but this is a monster contributor. Okay, so probable causes. Okay, we're very much a sitting society. Okay, especially with COVID, a lot of people did not leave their house a lot. Especially if we're in school, let's say pre-COVID when we talk about this, or hopefully when we return back, we do a lot of sitting. Okay, if you got to think all your elementary school, okay, you may sit 3-4 hours at a time. Okay, often people have really bad posture. Okay, they slouch like you see the woman here. Okay, a lot of that could be due to laziness. Okay, chair is not really comfortable. It could be just muscles aren't trained to support you for those periods of time. Okay, because a lot of people, it's tiring to sit up straight for long periods of time. Okay, it's very exhausting. Okay, so people, they probably don't train like their core. Okay, not really the abdominals, okay, but their core in general, to hold that posture for longer periods of time. Okay, a lot of people often have a lot of muscle imbalances. Okay, so like they have like a tight chest, which pull the shoulders forward. Okay, that's a really, really common one. Tight neck muscles pull their head forward. A lot of time we might be staring at the screen very, very close, so we're kind of like hunched over. A lot of these different things like habits just kind of contribute. Okay, and then we also get a lot of muscle tightness as a result. Okay, especially from all this like prolonged sitting. Okay, so possible injuries. Okay, hamstring strains, hip flexor strains, groin strains, low back pain, back strains. You see a lot of strains in here and pain. And usually all this is a result of going from usually sitting for long periods of time, getting really, really, really tight because we're sitting for so long, and then going to some like activity to where we're not ready yet because we need to kind of do a lot of like loosening up, if you will. Okay. Here's a little bit more about posture. So here's like pretty adequate posture here. Okay. Here's the plumb line going up and down. Here is the person showing anterior pelvic tilt. I mean, given he looks really awkward because he's obviously like has good posture, and so he's really trying to show it. Okay. So he has what I call ghetto booty. Okay. So really extreme lumbar curvature. Okay, makes you look like you have a big butt. Okay, but you have somewhat of this kind of proportion. So next time, or actually just anytime you're like walking around the grocery store or whatever, like look how people like walk and stand. Very, very common for people to have this posture. Okay, especially the lower cross center because you have the tight low back, tight hip flexors. Okay, because you see he's in whatever like 15 degrees of hip flexion. Okay, his abs are weak, and his glutes are probably really weak. Okay, as a result. Okay, so the posterior pelvic tilt isn't as common. Some people have it. It's not super easy to identify as like the anterior pelvic tilt. Okay, I see he's like really struggling to kind of like show you right now. Okay, but it's got be more of like this picture. Okay. Instead of being anterior, it's posterior, so his hips are rotated backwards, to where the anterior pelvic tilt are rotated forwards. Okay. So normally, with the normal pelvic rotation, or sitting low, okay, your ASIS, okay, your anterior superior iliac spine, okay, is that point that kind of sticks out in front of your hips, okay, and then your PSIS, your posterior superior iliac spine, those are like your dimples in your low back. Okay, those should be roughly level. Okay, I say roughly; they don't have to be exactly perfect. Okay. As a result, the length of your here's your hip flexors. Okay, your rectus femoris, and then here's your hamstrings. Okay, and the blue line is your groin. Okay, I just want to show that. Okay, so that's a normal length for those. Okay, so if you have like let's say lower cross syndrome or some kind of anterior pelvic tilt, okay, your hip flexors are shortened. Okay, your hamstrings are lengthened. Okay, and now your gracilis or your groin muscle is also lengthened as well as a result because of just where the hips sit. Okay, so say being normal. Okay, they're now tilted the anterior pelvic tilt. They rotate forward, so everything behind has to be longer. So as a result, let's say you're athletic, okay, and you're doing either sports or just working out, staying in shape, whatever it is, okay, and then you're doing a lot of running, okay, your hamstrings are already in a lengthened position, okay, and now you need to lengthen them even more, so this can contribute to a lot of like hamstring strains. The hip flexors can be shortened so you're not activating them properly. Okay, groin strains, as I mentioned previously, just because of the lengthened groin muscle. Okay, so what do we do now? Okay, so age plays a factor. Okay, obviously, once we get to a certain extent, like we're not as flexible as we used to be, our body doesn't react the same. Stretching is good. I wouldn't recommend maybe doing extreme as these kind of stretches. But stretching for the low back, okay, which is very, very difficult usually. Rolling out can give some pain, help out with some tight muscles. Massage always feels good, don't get me wrong. Stretching out really like your hip flexors, your iliopsoas is a big one. That's a big contributor just because it's such a really massive, deep hip flexor. And when we're sitting, your iliopsoas is lax. Okay, it's very loose. Okay, because it's only tight when we're in full like hip extension. Okay, but when we're hip flexion sitting, it's very loose. So a lot of time you get a lot of either not lesions, but a lot of tightness and like knots that build up. So then as we stand up, now all those knots still stay there because we haven't worked them out because we've been sitting for 4 or 5 hours. Okay, so we have a really, really tight iliopsoas muscle, which can contribute to a lot of lower back pain because as I showed you previously in a bunch of slides, where the origin of the psoas major is, okay, up on like the anterior surface of the spine and the kind of like on the sides on the transverse process, okay, really, really deep. A lot of time you get a lot of lower back pain right in the spots where it attaches, okay, like right on the sides, because that iliopsoas is so tight. Okay. Also do a lot of core strengthening and activation. A lot of people don't activate their core. Okay. I say activate is contract it normally. Okay. Normally your core has to contract during everything. Okay. Any motion, when I put my arm above my head, my core has to contract to stabilize my core so I can lift my arm more efficiently. Okay. Hamstrings and gluteus maximus are usually either overactivated or not activated. So what I mean by that is a lot of people, very, very common for whatever activity they're doing, especially like running, whatever it is, if they come to me with a hamstring strain, I'm going to first look at activation of the gluteus maximus. Okay, because your gluteus maximus should be your primary hip extensor, should be. But a lot of time, the body just relies on their hamstrings for hip extension. Okay, which you have an overactivity of your hamstring muscles because it's doing all of this really extreme hip extension to where the biggest muscle in your body, the gluteus maximus, is not activated. Okay, so the best way of doing this, okay, sit on your hands. Okay, put your hands under your butt. Okay, now I want you to contract your butt. Just squeeze. Okay, often this is a really good one I do in class, but a lot of people do not know how to activate their glutes. Okay, they can't get it. Okay, but some people have like no issues with this. They're like, all right, so I want you to. It's kind of a weird thing, but okay, just go off and on contract your glutes. Okay, so you should have this like almost like up and down motion of like contracting the glutes. Okay, now alternate, and a lot of time people can't do that. Okay, it's like they can get one but not the other. Okay, that's the first thing I'll do. Then I'll try and teach them how to do glute activation before hamstring activation, because it should go. The activation pattern should be almost all the time go proximal to distal. Okay, so it should be glutes then hamstrings for like hip extension. Okay, So for the hamstring strains, I mean, I'm a little ahead of myself on that, which is the next few slides. I'm going to first try and train them to contract their glutes, okay? And then once they can do that, then all right, now I'm going to walk, but I want you to use your glutes for extension. So you got to squeeze that butt cheek every time you take a step to try and propel yourself, okay? Looks really, really awkward. It's kind of funny for me to watch, but it's a really good activity to try and like teach people how to activate that. Okay, and then once they can kind of get down like the walking kind of motion, not saying they have to do this forever, but just like train them how to activate it. It's more of like a mental thing of how to train like the mental body kind of awareness and sync. And then we'll actually get to more like functional stuff like squat or like a lunge. I want you to lunge, but now I want you to use that glute. I want you to contract that glute to now like propel yourself up. Okay, same with a squat. And oftentimes people get super, super sore because they're not used to that activation pattern. All right, the next one is pronation distortion syndrome. Okay, so this is caused by foot pronation, genu valgus, hip pain, and low back pain. Okay, so a lot of time we'll do a squat mechanics for this. Okay, it kind of helps tell this a big picture about that. It's very common amongst the general population. Usually some kind of muscle weakness and tightness is the primary cause, usually. Oftentimes you have possible congenital abnormalities like excessive Q angle. Okay, Q angle is just the different angles kind of in your hips and how it plays. Some people, like usually women, have a little greater Q angle than men just because of the wider hips. Nothing like wrong with that. That's just how it is. So when I talk about a lot of this, it's going to be pronation. So the pronation is going to be pretty much everywhere in a way. Okay, so it's going to start at the foot is a big one. Okay, so your foot's going to pronate, so it's going to kind of dive in, which is a result of an internal rotation of your tibia and femur. Okay, which puts a lot of pain on your back because everything's kind of stretched out and it's trying to stabilize it best it can. Okay, and then wait a little bit. Okay, I have another picture. Okay, so often with this, it could be a tight groin. Okay, so a tight groin can really kind of pull everything in. Tight calf muscle. Okay, I say calf because there's only one out of the two because your gastrocnemius has two heads. Okay, so usually the medial head's usually almost all the time overactive. Okay. So you just feel right in the muscle belly on the medial side. It's usually very, very tender. Okay, you're a little not. It's common. It's a tender point. Whereas the lateral side is usually not as tight, usually. Okay. Oftentimes, really weak hip flexor. Okay, iliopsoas predominantly, because the iliopsoas does do, as I mentioned previously, hip external rotation to an extent. Okay, so a weak hip flexor can contribute to some of that. Weak glutes, okay, because your gluteus maximus is also a major hip external rotator as well as extensor. Okay, it's usually really, really weak. Let me think. Those are the biggest ones. Okay, so it's kind of look like this. Okay, so you have this valgus force, this genu valgus force. Okay, oftentimes the foot you're going to have pes planus, if you remember the lower extremity PowerPoint we talked about. Okay, or like flat foot. So you're going to have your foot's going to kind of curve out like that. Okay, everything's kind of internally rotated. Okay, so that gives you a lot of strain on your MCL. Okay, which can cause MCL sprains and just pain. Patella tendonitis. Okay, right in here. Okay, because the pull right here of your quad goes this way. Okay, but that's almost going to go around your knee, so you're just on the medial side of your patella tendons, which should be really kind of tender and inflamed. Okay, this also predisposes you to ACL tears. Okay, if you mentioned about the knee, that the cutting motion, well, you're already like in the motion already. Okay, so it really needs a really bad misstep. Okay, because remember it's the cutting, so if you're going to cut, this is almost like you're going to change directions. Okay, oftentimes you get a lot of IT band issues. as a result of the just abnormal circumstances. And you get some Achilles tendonitis, okay, especially medially, just kind of like the patellar tendonitis, okay, on the medial side, just from it's trying to kind of over correct. Okay, so what to do? Okay, a lot of strengthening of the lateral posterior hips. Okay, so gluteus maximus, gluteus medius is also a really, really good one. It's like clamshell squats. Okay, also like attack the iliopsoas. Okay, so just like high knees, put weight on the ankle. Not like fast high knees, but just like lift one leg up like 10, 15 times. Okay, like 3 or 4 sets depending on whatever my goal is. Okay. Stretching of the gastrocnemius and soleus, okay, your calf muscles. Orthotics can help, okay, especially with that pes planus, okay, to try and lift up that flat foot to a little bit higher, okay. And then correct squatting and running mechanics is also a really, really big one. So you can see a lot of the pronation distortion syndrome if you have someone do a squat. Okay, just air squat and have the arms on their head, whatever it is, and just squat down. You can see like their knees dive in, which is really common, and stuff like that. All right, hip labral tears. Okay, this often occurs due to repetitive movement, such as running or pivoting, results in degeneration or breakdown of the labrum, as you see. Can also occur acutely due to hip dislocations. A lot of time you can have some kind of impingement, which is whatever reason either the labrum or the tissue in the capsule gets kind of caught into the labrum and kind of get impinged in the joint. So have to go in and just kind of like remove portions of it. Okay. Most of the time, hip labral tears are asymptomatic. Okay, just how it is, which they have no symptoms. Can present with clicking, locking, stiffness, limited range of motion, especially because the wearable fragments can kind of get caught in the joint. Can have a lot of pain throughout the hip and groin. That's it for hip labral tears. And then quad contusions. Okay, this is a big one. So on quad contusions, which is very, very common, especially in contact sports, usually some kind of direct impact is the cause. Okay. You can like have a nice good one like this, or can be like a smaller, depending if they have ecchymosis or not. And ecchymosis is just a discoloration. Okay, so the management of this is always ice on the stretch. Always ice on the stretch. Okay, so if you have the purpose of on the stretch, it doesn't even have to be like full knee flexion, just whatever they can do comfortably. Okay, so that doesn't allow for all that any blood that has occurred because of that impact to sit there. So it has to move out and away. Okay. So you put ice on there, just put like a little ace wrap to keep them in knee flexion, and that's really it. Okay, you can take NSAIDs, okay, Advil Relief, crutches in severe cases, okay, really, really bad quad contusions, like I'll put them on crutches, just because it takes off all like the weight off that leg. No massage or heat or alcohol for 72 hours at least. Compression wrap can help out a lot. And just try and get range of motion back as soon as possible. Okay, and that could just throw them on a bike for like 15, 20 minutes, a few times a day, just try and get it moving. Okay, that also helps to pump all that blood out of there. Okay, because if that blood sits there, you're going to have what's called heterotropic ossification, which was previously called myositis ossificans. So this is formation of bone, okay, intramuscular due to repeated blunt trauma. Okay, all that blood sits there, like within the muscle, calcifies and turns to bone. Okay, usually a result of repeated quad contusions. So like running backs in football, I'll have them even double pad their thighs. Oftentimes they'll wear like a girdle, which is like it's kind of like underwear in a way, but it has all the pads built into it, which is very, very common now in football because less extra padding to deal with. And then we'll have them put like the real old school like thigh pads in. And on top of that for the running backs, because they're just really prone to some of these. Okay, treatment. Okay, they're gonna do an X-ray maybe about a month post-injury because it takes about that long to see kind of bone kind of formation to occur. They got a lot of pain, swelling, weakness, decreased range of motion as a result of all that like bone within the muscle. Sometimes you can even feel it. Really, really tender. You can do conservative versus aggressive treatments depending on whatever it is. Obviously, control to your physician. The most aggressive I ever did was I rolled it out to try and get out as fast as possible. Super, super painful because you're trying to break bone in a way. Yeah, he never came back when he had it. But it did help, but he never came back. I don't blame him. Okay. Oftentimes could result in a surgical removal, which is what you're trying to do. Okay, and this is what it looks like on the X-ray. You saw a little bit of this in when I talked about the elbow, because you have the same thing in the elbow. This is kind of early stages. So for this, I'll have to go in and like remove it. All right, next one is quadriceps strains. Okay, use some kind of force, stretch, violent, forceful contraction. Okay, of the muscle. Usually, rectus femoris is the big one. Okay, so sign symptoms: okay, painful tenderness, spasm, loss of function, possible ecchymosis, which is the discoloration. Complete tear will leave deformity and disability. Okay, so this is probably a grade 2 tear because there's a void. Grade 2 or grade 3. Okay. Grade 1, you're not going to have that kind of void. Okay, so different grades. So grade 1, complaint of tightness in the front of the thigh, near normal walking issues. Swelling will be limited, if not there. Mild discomfort during palpation. Okay, really kind of like not a lot. Okay, so grade 2, abnormal walking cycle. Okay, so that's just gait. Okay, maybe splinted in extension. Swelling is most likely noticeable with pain on palpation. Possible defect in muscle, okay, because you've actually torn some parts of the muscle. Resistant knee extension will produce pain. Okay, so they're trying to, if you're just try and do some kind of like muscle contraction of the muscle, will cause a lot of pain, obviously. Grade 3, possibly unable to walk. Okay, pain with palpation, unable to perform knee extension because the muscle's not there. Grade 3 is a complete tear, just know that. Isometric contractions may produce defect or bulging in muscle belly. Okay. So management. Okay, so neoprene sleeve may provide some added support, keep things warm. And that's just kind of like sleeves, like compression sleeves. And that just kind of helps like a little bit, but rest is going to be the best thing because it's just going to keep kind of aggravating them if you let them keep doing whatever activity it is. Okay. Grade 2, ice compression for about 35 days, then gradual increase in isometric exercises, and then you do some pain-free range of motion stuff. Okay. Okay, limit passive stretching until later. Okay, so don't do any stretching until later on. Okay, don't worry about that. A lot of people want to stretch like it because it might feel better. No. Especially because it might feel like really, really tight and like painful. They're like, oh, I want to stretch it out. When it's tightening up, especially the surrounding musculature, to protect itself so it doesn't stretch. Okay, grade 3, crutches for 1 to 2 weeks. Okay, then you try and get the normal walking gait back. Make sure their full range of motion's back. Compression can help with some supports. May require 12 weeks until full return. So that takes a long time, especially for the major muscles. Okay, and you're better off if it's right in the middle of the muscle and right in that muscle belly. If it's more towards the tendon, it takes longer because there's less blood flow towards that. Hamstring strains, kind of very similar. Most common thigh injury. Okay. Often caused from like fatigue, posture, change in role from hip extensor to knee flexor. Okay, because your hamstrings do both, knee flexion and hip extension. Okay, so that quick change can often result in that muscle strain. Posture issues, I mentioned about that. Leg length discrepancy. Okay, one leg could be like longer than the other for a number of different reasons. Flexibility issues, strength imbalances. Overstretching is a big one. So signs, symptoms, okay, muscle belly or point tender at attachment of pain. You can have hemorrhage, pain, loss of function, possible discoloration. There's that ecchymosis. So grade 1, soreness during movement and point tender. Okay, so you have a little bit of muscles torn, especially the micro tears. Grade 2, the partial tear, identified as sharp pain or snap, severe pain, loss of function, a good amount of muscle tears. Let's see what else. Grade 3 is rupturing of tendinous or musculature tissue. This is where you're going to have the major discoloration. Okay. Swelling, edema. Loss of function, obviously. You can have a palpable kind of like void in there. Okay. So management, okay. Ice them, rest them. Okay. Give them some meds for pain is always good. So grade 1, don't resume full activity until complete function is restored. Okay, really, really important. Okay, and even then, with like any kind of muscle strain on the recovery, once they kind of get back and it feels like great, ideally I want to hold them off another week at least, maybe 2. Okay, because it always going to happen. It's going to feel great because everything's starting to heal really good. They have about 80% of their muscle strength. And then they're going to go back and they're going to do a full 100% activity, and it's going to strain again. Okay, happens like 90% of the time. Okay, so often we keep them off extra time. I mean, you're still doing kind of like that active rehab to try and get them back for another like week or 2 after they think, and they kind of hate you for that, but they're going to have a better season as a result. And grade 2 and 3 should be treated conservatively. Grade 3, you always want to refer to a physician to see any other issues that may occur as a result. Because any kind of grade 3 or complete tear, you always want to refer to a physician before anything happens. All right. Piriformis syndrome, or often called sciatica. Okay. So this is some kind of nerve gets irritated. Okay. Usually it's the sciatic nerve. Okay. You see how all the nerves come off the back and it gets kind of trapped by the piriformis muscle. Okay, more common in women. Typically caused by tight piriformis as the nerve passes underneath the muscle. Okay, so there are a few other things that cause this. Okay, it could be some kind of nerve entrapment. Okay, or pinched nerve up in the back. Okay, and the pain you just feel more down here in the hip. Okay, that's the first thing. Or it's from a tight piriformis or an overactive piriformis muscle. Okay, so it's really, really important to identify first to see what you want to do. Okay, because if it's somewhere in the back of the nerve root, I might send them to a physician first to kind of rule out anything else that happens with the back, whether they have some kind of slip disc, back sprain, like one of the deeper ones, other weird issue, bone spurs, whatever it is, before I start really kind of like focusing on like on my rehab and whatever it is for that. Okay, but if a lot of their pain is down here at the piriformis muscle, then I want to start attacking that. Okay. Oftentimes the pain will radiate down the whole posterior lateral thigh and into the calf and foot. You're gonna have a lot of weakness. Okay. Severe case should be treated for like 2 or 3 weeks rest. Okay, foam rolling helps a decent amount. Okay, stretching, the figure 4 stretch and knee to opposite chest stretch is really, really good. Let's see. Oftentimes the piriformis muscle is overactive. Okay, because it's so tight. But this is one of those things. At least in my experience, it's going to get worse before it gets better. Okay, because you start doing activities that are going to stress the piriformis a little bit. Okay, to try and get it back to its normal state. Okay, in that case, you do have to activate it. Okay, which is clamshells is a common one, monster walks, squats, a number of different things. Okay, and this is a thing you kind of like think outside the box because like what is the root cause here? Okay, there could be a lot. Because you kind of look at everything to identify. All right, so this is a possible thing. So you try and fix all of those things and see how it affects this. Okay. Last one I'm talking about is hip pointers. Okay, hip pointers is a contusion to the iliac crest. Okay, the kind of ridge on the ilium, as I mentioned, like the slide 3 of this. So signs, symptoms, okay, pain, spasm, temporary paralysis of the area, decreased ability to flex your hip. Hip flexors are really, they're not a bad injury, but they're very, very detrimental, okay? Especially in like football and contact sports where it's more common to get. A hip pointer, even though you might not even have a bruise, it'll shut down your entire leg, and you can't do anything about it. Okay, it's just time. That's all it is. Okay. So, ice for pain, if they have any, give them some drugs, help with any inflammation. Severe cases involve bed rest. Bad ones, you want to do referral to rule out a fracture to the iliac crest, because that can't happen. Recovery can be like 1 to 3 weeks, give or take. The worst one I ever saw was I was working high school football, and we're up in Bakersfield, and one of my wide receivers was going. He went to catch a ball down the sideline, and he kind of like overstretched. He was trying to. He didn't fall yet, but he was trying to kind of. Most of his body was going forwards, and he couldn't like maintain himself, so he fell forward. But he ended up he fell like 5 feet out of bounds. Okay, but he rolled another like 5 feet into a concrete lip. He right on his hip. Super painful. He bruised roughly this bad, which is not like crazy. But it took him out a month. Okay, and he couldn't lift his leg. And like a week later, he's like, I got no pain. I just can't lift my leg. He goes like, I can feel it, but I can't lift. I got no strength. So it took a long time to kind of bring him back. Okay, there's not really anything they can do about it besides just try and get like range of motion and just try and keep things moving. But it's a very, very detrimental, non-serious injury. Okay. And that is the hip.